my uh, uh, purpose of my talk is to show the need of the pot technique. Now I try to move my presentation, but doesn't move now. Okay, now move. And we know that the proximal optimal uh, tech optimization technique, it's very important to perform, especially in bifurcation, to prepare the kissing balloon, to prepare the recrossing the branch, and to oppose very well in the proximal part, especially in the tapering vessel. And the problem that we know is not able the very short balloon with very short shoulder to avoid the outside stretch against the vessel wall or to avoid the geographical miss. So this is an exemplificative cartoon to show very well the importance of the short shoulder to have a big pressure against to the edge, but not only, very important, another, to concentrate the force in a very small area to optimize the result. And the another point that we discuss is the situation that we meet every day. After the deployment of the stent, we need a post dilate. It's crucial to well opposed to very good expansion to achieve a very big area, and we use a different type of NC balloon to post dilate, and sometimes we have different problem, long shoulder, not compliance, so very low compliance. The POT PTCA balloon is a very short shoulder compared with the other competitors. Another important is a very low entry profile. Another important point of this balloon is ultra low compliance to assure a controlled minimal grow up without avoid the dog bone effect. This is another technical specification. I believe that the crucial point is a very short balloon, not only especially in the big size, 4.5 and 5. So now I show three cases where the pot, I believe, it's crucial, and in my mind, could change the philosophy of the PTCA. Sometimes we discuss in the Congress, in the meeting, the need of pot, but I'm not so sure that in the real world the use of pot is mandatory and is used in every bifurcation. This is a simple case, 78 years old male with hypertension, diabetes, normal function, and we present with Canadian class 3 angina with a very calcified LED diagonal and Medina. We perform, and my idea is to perform a provisional stenting in the second diagonal because it is completely diffuse and not so big diagonal, and no predilatation of the diagonal branch to avoid dissection, only pot to avoid carina shifting. And then we complete with the T-stent in the proximal LED and diagonal branch. You see very well the two bifurcation. This is the first one, but this is a crucial bifurcation with the diffuse disease calcification. And you see a tight lesion with calcified, but it's very important how often happens the change of the diameter between the proximal to the distal. A typical case when we need a pot to avoid a big expansion distally with a bigger stent, or under expansion proximal with a undersized stent. I choose a 3.8 DES after preparation with NC balloon 3.2 at 20 atmosphere, and we and then we implant the stent, drug-eluting stent 3.8 millimeter in length, and we perform a POT only proximal to the carina with the POT 3.5, 16 and 20 to open very well the end if need to recross easily. You see the result. We see a little no change between the first, sorry, we don't change the imaging, and appreciate a lot a completely big apposition than here. I believe that is a simple, but in this case, it's crucial to avoid a carina shifting. Then I finish with the tap and the stenting in another big vessel, and this is a final result. This is a first case. The second case is more complex, and the typical case of trifurcation. 52 years old male with hypertension, diabetes, and normal ejection fraction, stable angina in unprotected left main trifurcation in patent RCA. My idea is to perform an imaging IBUS guiding PCI and planning a two-stent technique and choose the preparation. This is the lesion, but you see very well that the big ramus and also the IBUS for me it's crucial because show how the ostial of the circ and the ramus is very diseased and is a real tree bifurcation. I prepare and I wire in the three vessel, and I decide to perform a prepare very well the lesion, and then I prepare the ramus with the drug coating balloon on ramus 3.0 50 millimeter in length Panterolax, and then I perform a mini crushing, and then to avoid the complete distortion of the anatomy, I perform a pot balloon 4.06 millimeter 20 atmosphere, final 3 kissing balloon, and then proximal pot balloon. I don't have imaging of the pot, unfortunately. This is a final result, but it's very important. With the IBUS, you show very well the big area of the lumen. You see the crux carina and the LED ostium, LC ostium, and also the ramus without stent is a very big. I believe that is a typical example of the 8 images of the IBUS, so the carina increase a lot, but also in this case, the common part of the left main increase. And finally, a typical case that of sometimes happening in our lab, where I test this short balloon with efficacy in the treat the problem that I meet during the procedure. So this is a patient, 70 years old male with recent lateral ST elevation MI, treated with primary PCI, but unfortunately, probably due to the movement of the patient or the stress procedure during the implantation, the stent into the proximal circ, we appreciate a little protrusion, but I'm not so sure it's so little. But unfortunately, we do a complete vascularization with the LAD. So our strategy is to guide with the IBUS the involvement of the left main with the stent protruding, and then decide the strategy. This is a imaging. You see this is a lesion of LAD that I decide to complete, and you appreciate a big ectasia around the diagonal branch. This is after, and this is proximal, but you appreciate in this screen a protruding stent. It's not so easy to cross with the wire, but cross, and we perform a small predilatation with a 2.2 balloon, and then we perform IBUS. IBUS, and then I show that the stent protruding, and I cross the first part and the second part of the vessel. So it is not possible to perform and mini culotte. So I implant the stent distally, and then I perform a POT balloon 3.5 and distally 3.2 POT. This is a typical case where we can use a POT PTCA balloon to progressive tapering of the stent distally to proximal, changing the diameter to concentrate. In this case, it's useful because we have a ectasia, and I perform a 3.2 here, and he decide to use a 3.5, and then after we put another stent across the stent in the left main, and left main to LAD, we prepare with 4.2, then post-dilate with 4.2 POT balloon, and then post-dilate the left main, you see very well proximal to the carena, with the 4.5 6 millimeter in length POT balloon. And this is a angiographic final result, but I show to you the case with the, you see very well the cross, the stent is not completely opposed after crossing. This is a stent that I appreciate in the circ, and also after POT balloon. And this is the final result, but it's very important. This is ectasia and the origin of the circ, but now you can appreciate a complete expansion after 4.5 balloon of the stent against the vessel wall. This is a kind of demonstration where the combination of the technology that we have, the POT balloon, a very short balloon, with the IBUS, is possible to resolve a potential complex situation. I believe, in conclusion, the key point to use in my mind the POT PTCA balloon is to optimize technical proximal technique to avoid carena shifting. First of all, I believe a lot in this technique to concentrate high pressure in focal area, and with this type of balloon is possible to reduce high pressure, especially in the carena or in the distal part where is not needed segment, to optimize post-dilatation to avoid geographical means, and this is due to or to avoid the high pressure trauma outside the stent, especially due to the very short shoulder, and also to modulate high pressure post-stent dilatation. In my mind, in very long stent, to perform a sort of tapering, changing the diameter of the short balloon. And another big point that I use the POT PTCI is to flare the stent and the ostium to open very well, and especially to avoid the suboptimal expansion and to facilitate the possible future re-engage. Thank you for your attention. Any comment?
Okay.
I don't know. Do you hear me?
Yeah, I can hear you, Dr. Galli. Yeah. I need to share my screen firstly.
Okay. Now
Yeah.
I close okay.
Okay. Thank you.
Please.
Okay. Okay, and thank you for Dr. Galli. And according to our agenda, we now have 5 minutes for the discussion. Any question from our experts or our audience? You can show your questions on the chat box.
Okay, Michelle, I can start. Just a little comment of Stefano's presentation. I appreciate and completely agree with your conclusion, Stefano. Compliment for your presentation. I see that in the first case, also in other 2 cases that you presented, you used the stent boost or clear stent, depends of the machine that you have in your cath lab. I like the clear stent. Do you use the clear stent or stent boost in every procedure in a post-dilatation setting?
Absolutely, yes. In our lab, we have a clear stent. I believe, for honest, is not the best. I believe that the boost of Philips is better. But I believe that a part of the IBUS, it's crucial to use a change completely our life, because normally with the short balloon, but not only with the short balloon, also the post dilate, we in our lab we use always this zoom magnification to optimize, and I believe it's very important. It's important not only to see very well the stent, especially in the thinner struts, but to see if you change or not. And sometimes we use also with the inflating balloon to appreciate if the balloon is full expansion, especially in calcific. And then I believe it's very important when we perform a provisional stenting to appreciate if the open struts is good. This is very important. Sometimes when you perform a pot side pot, it's very interesting because you perform a pot, then you perform a side. It's crucial to perform the second and the final pot proximal to avoid another shifting of the stent against the diagonal. I use in every, almost in every procedure.
Great, great.
So Stefano, thank you for your presentation. Just a quick question from Spain.
Sí, Pablo. Yes, Pablo.
I show your nice trifurcation case.
Yeah.
So it makes sense, of course, to start with pot, but in which wire do you send the pot in? Because it could be the main vessel, so the LAD, or it could be the central wire, just to make like a symmetrical opening. So what are your thoughts on this?
I agree. You see very well that they use a short balloon only in the left main. Okay, and then I perform a trikissing to open the ostium. But in this is exemplification to use a pot to facilitate the crossing the balloon and the wire into especially into the ramus. I believe this is another sense of the pot technique.
But the pot was on the primary wire, so the LAD wire, right?
Yes.
Yes.
Okay, thank you so much for Dr. Galli's detailed explanations.
Thank you.
And then, thank you.